we have Dr. Chathurika Kempitiya, who is a senior registrar in cardiology at the National Hospital, Colombo, who is going to speak on MINOCA and INOCA, what, who, why, and how. Thank you. Over to you.
Thank you, sir. And good afternoon, everybody. I am Dr. Chathurika, Senior Registrar Cardiology. Today, my topic is MINOCA and INOCA, what, who, why, and how. So, MINOCA stands for myocardial infarction with non-obstructive coronary arteries, and INOCA stands for ischemia with non-obstructive coronary arteries. So, within next 20 minutes, I will be talking about what is MINOCA, who is more prone to get MINOCA, why it is important to diagnose MINOCA, how MINOCA should be investigated, and how MINOCA should be treated. And then I'm going to repeat the same W and H questions for INOCA as well in a summarized manner. So before going into my presentation, I would like to present you a patient who's a 40-year-old previously healthy female, mother of 3-month-old baby, presented to us with typical ischemic type chest pain. ECG showed anterior ST elevations and tropi was elevated, and 2D echo showed elevated territory ischemia. We rushed her to the cath lab and did the coronary angiogram. But it was normal. But we didn't stop at that. We put a tiny ultrasound probe into the epicardial artery, and that has showed something like this. There's a separation of adventitia and media of the coronary artery. There's a dissection which has got intramural hematoma. This condition is called spontaneous coronary artery dissection. So, is this MINOCA? We'll move on to the definition of MINOCA. The conditions comes under MINOCA should have acute myocardial infarction definition according to the 4th universal criteria of MI, and non-obstructive coronary arteries on angiography. That means less than 50% stenosis in angiogram. And they shouldn't have any alternative diagnosis as well. So this is the criteria for MINOCA. So our first case, the patient has had acute myocardial infarction according to the 4th universal definition, non-obstructive coronary arteries on the angio, and no alternative diagnosis as well. So this is MINOCA. So I'll present you another case, 50-year-old woman presented to us with severe chest pain during the son's funeral, and anterior ST segment elevations are there, tropi was high, and 2D echo showed apical hyperkinesia. We did the coronary angiogram. Again, it was normal, but we didn't stop at that. We did the left ventriculogram, which has showed apical ballooning. And can this be MINOCA? So, second case, there's acute myocardial infarction according to the 4th universal criteria of myocardial infarction, and non-obstructive coronary arteries on angio. But there is an alternative diagnosis. This is Takotsubo cardiomyopathy. So, Takotsubo cardiomyopathy and myocarditis not included in the recent definition of MINOCA. This can clinically mimic MINOCA, but they are distinctly different syndromes. So, they should be separated. They should be considered separately. So, Takotsubo and myocarditis out. But what are the conditions comes under MINOCA? Heterogeneous conditions grouped under this umbrella term. There could be atherosclerotic causes like plaque disruption, which we can't pick up in the angiogram. And there are non-atherosclerotic causes. Main causes are the vasospasms in the large arteries, coronary embolism and thrombosis, which we can't pick up again in the angio, and spontaneous coronary artery dissection and microvascular dysfunctions. So, we'll go one by one about these causes. What is plaque disruption? This is actually cause 1/3 of MINOCA. Plaque rupture, plaque erosions and calcific nodules, which we can't pick up in the angio, comes under this condition. This can cause MINOCA by thrombus formation and can cause myocardial infarction. By distal embolization, superimposed coronary spasm, and transient complete thrombosis with spontaneous thrombolysis. So, we can't detect this in the angio. But usually they have minor atherosclerosis somewhere in the angiogram. The angiograms are not completely normal. There's minor atherosclerosis somewhere in the angiogram. So, that is the first cause for MINOCA, plaque disruption. The second one is large coronary artery vasospasm. Around 4 to 6% 46% of patients with MINOCA have vasospasms. Intense vasoconstriction, more than 90% vasoconstriction, can compromise myocardial blood flow, and prolonged episodes can cause MI as well. They present with rest angina with dynamic ST segment elevations in ECG. And the cause for the vasospasms is coronary vasomotor tone dysfunction. Vascular smooth muscle hyperactivity is the main cause, and inflammatory mechanism also plays a role. Drugs and toxins like cocaine, fluorouracil can cause vasospasm, and it can occur spontaneously as well. So third important cause for myocardial infarction with non-obstructive coronary artery disease is spontaneous coronary artery dissection. There's a separation of media and adventitia. There's a dissection of coronary arteries, and the intramural hematoma protrude into the lumen and cause the obstruction. Usually, these patients having underlying vasculopathy, and there can be a precipitating stressor like emotional stress, like extreme physical activities. After these stresses, this patient can come with typical ischemic chest pain. And this spontaneous coronary artery disease can be associated with vascular diseases such as fibromuscular dysplasia, and it can be associated with pregnancy as well. So our first patient is a postpartum patient presented with spontaneous coronary artery disease. The next important cause for MINOCA is coronary emboli and thrombi. It can cause MINOCA if it involves the small arteries, which we can't pick up in the angio, or if partial lysis of the epicardial large artery coronary thrombus occur, then it can cause myocardial infarction with non-obstructive coronary artery disease. And this can occur with cardiac interventions as well. So the next important cause for MINOCA is microvascular dysfunction. This is an unknown entity for a long time, and this was initially named as syndrome X as well. So what is coronary microcirculation? The tiny arteries diameter less than 1 centimeter comes under microcirculation. It's not easily visualized, and it's a challenge to assess these arteries as well. But it accounts for 70% of coronary resistance. So this large coronary arteries, our right coronary, our left coronary, we all know, but there's a large, complex, tiny artery system beneath that, which we can't usually not visualized, which is very challenging to assess, but it can go wrong structurally, functionally, and cause microvascular dysfunction. So this is another picture of these tiny arterial complexes, the microvascular system of the heart, which can go wrong and cause diseases, which was an unknown entity for a long time, but now there are objective ways to assess. So this is another picture. This is a cross-section of the heart showing the tiny arteries going and supplying the myocardium, and this subepicardial portion of the myocardium, which is more away from the large arteries, is more prone to get ischemia. So this microvascular dysfunction can be in two ways. The tiny arteries can structurally go wrong, which can cause structural remodeling, and they can go functionally wrong as well because of the vasomotor disorders. This entity largely contributed to the stable angina, ischemia with non-obstructive coronary artery disease. However, in extreme situations, it can cause myocardial infarction as well. But because of the myocardial injury due to a ischemic or non-ischemic cause, in turn can cause microvascular dysfunction as well. So in MINOCA, there is a dilemma. Is it a cause for acute myocardial infarction, or is it a consequence of it? So now we have covered the main causes for myocardial infarction with non-obstructive coronary artery disease. So who is more prone to get MINOCA? It's younger female. The average age is 58. 58 is not younger, but compared to the obstructive coronary artery disease, this is a younger age. And 50% of myocardial infarction with non-obstructive coronary artery patients are women. And if woman gets a MI, chance to be MINOCA is twice as high as a man. So why common in women? Because the female coronary arteries are different to male coronary arteries. They are small diameter. The atherosclerosis is diffuse. By the men, they are having focal atherosclerosis and they are having less calcification, more soft plaques. So we can't pick up the plaque ruptures during the coronary angio. And they are more prone to get vasomotor dysfunction. And they are more prone to get epicardial and microvascular spasm. Estrogen fluctuations plays role in vasomotor dysfunction. So, then why it is important to diagnose MINOCA? No obstruction shouldn't mean no diagnosis. MINOCA accounts for 8 to 14% significant percentage of acute myocardial infarction. And the treatment is cause targeted mostly. For the spontaneous coronary artery dissection, as example, we do not start statins and we do not stent as well because there's a chance of spontaneous healing. And vasospasms, we usually do not give beta blockers. And for the microvascular disease, usually for the vasospastic anginas, calcium channel blockers helps. So treatment is different. So diagnosis is important. Is MINOCA bad? Not as obstructive coronary artery disease, better prognosis compared to patients with obstructive coronary artery disease, but lower survival rate than healthy individual. It's not completely benign. So how do you evaluate MINOCA? So there's a traffic light sequence to evaluate MINOCA. First, we have to keep the MINOCA as a working diagnosis at the time of the coronary angiogram with non-obstruction. And we have to exclude the other causes for tropi rise, such as pulmonary embolism, sepsis. And then we have to exclude the overlooked diagnosis. We have to reassess the angios. We have to look for the missed obstruction. We have to look for the myocardial injuries, which can closely mimic myocardial infarction. Then once we diagnose MINOCA, then we have to look for the cause. We have to look closely at the large arteries, and then we have to look at the microvasculature as well, and then we have to look for the vasospasms. And thrombophilia screening also plays a role. So this is the traffic light sequence of evaluating MINOCA. We have to stop and we have to think about the other causes, the alternative diagnosis for elevated tropi. Then we have to look for the missed obstruction or myocardial injuries. And then when we diagnose MINOCA, we have to look at the large arteries, small arteries, vasospasms, and we can do the thrombophilia screen. So during this process, the cardiac MRI helps a lot. In studies have showed around 87 of patients with MINOCA, underlying cause is identified with cardiac MRI. The late gadolinium enhancement pattern helps here because in the ischemia, the subendocardial portion is more prone to get ischemic, and late gadolinium enhancement in myocardial, the cardiac MRI occur in the subendocardial portion in ischemic causes. However, in cardiomyopathies and myocarditis, the late gadolinium enhancement occur in subepicardial portion. So this is a picture of various cardiac MRIs, which is showing the late gadolinium enhancement pattern. In the ischemic cardiomyopathy, there's a subendocardial portion late gadolinium enhancement, and in other causes, there are different patterns. This is again a graphical representation of late gadolinium enhancement of cardiac MRI. So with cardiac MRI, we can differentiate non-ischemic causes which can closely mimic MINOCA from ischemic causes. So then we have to look closely at the large coronary arteries. IVUS and OCT helps in here for the detection of unrecognized causes of coronary angiography, especially thrombosis, plaque ruptures, or spontaneous coronary artery dissections we can detect by here. In the IVUS, we put a tiny ultrasound probe to the coronary artery disease and we can get the 2D images like this. And in the ultrasound, we put sound waves. If we put an infrared wave to the coronary arteries, then we can get a high resolution image like this. This is OCT, optical coherent tomography, which can pick the missed plaques, thrombosis, spontaneous coronary artery diseases in the large coronaries, which can account for MINOCA. So, recently published HARP MINOCA study has showed around 85% of patients with MINOCA cause should be identified with the OCT and cardiac MR. And if we suspect coronary thrombosis or emboli, thrombophilia screening also helps. And then we can look for the vasospasms. We can inject intracoronary acetylcholine and see with the intracoronary acetylcholine, if there are large coronary artery spasm, angiogram looks like this with ECG changes and symptoms. If the angiogram is normal with the intracoronary acetylcholine and still the patient is getting symptoms and ECG changes, then we can suspect microvascular spasms. So that is how we evaluate vasospasms. Then we can assess the tiny arteries of the heart as well. There are objective ways to assess tiny arteries now. There are non-invasive ways as well as invasive ways. This is a picture of functional cardiac MR, which helps to assess the microvasculature, and we can put a guide wire to the large coronary arteries, and we can objectively assess the microvasculature as well, the resistance of the microvasculature and the ability of the microvasculature to dilate in hyperemia. So there are objective ways now to assess the microvasculature. So how do you treat MINOCA? So we have to give the emergency supportive care as other MIs, and we have to keep a working diagnosis approach for patient evaluation. Then we have to give the course targeted therapies. So for the plaque disruption, we can treat as obstructive coronary artery disease as well. But for the epicardial vasospasms, we have to give calcium channel blockers. Usually a very high dose, around 240 milligram BD dose of diltiazem sometimes needs for treating vasospasm. And for the coronary embolism or thrombosis, we can give anticoagulation. And for the spontaneous coronary artery disease, usually we do not start statin. Usually it has ability to heal spontaneously. And if it is not, then we can try stenting. And microvascular dysfunction management, I will deal with the INOCA. So, no obstruction shouldn't mean no diagnosis, but could all MINOCA patients get a definite diagnosis? Around 8 to 25% of patients, despite optimal workup, cause of MINOCA remains undetermined. This entity is categorized as MINOCA of unknown cause. So, this entity we can follow up as acute coronary syndrome with obstructive coronary artery disease, and we can treat for the most probable causes of MINOCA. Those are vasospastic angina, coronary plaque disruption, or thromboembolism. But for the evidence for the dual antiplatelet is less. However, aspirin, statin, AC inhibitors and has showed a benefit in treating MINOCA of unknown cause. And if we suspect vasospasms, calcium channel blockers also we could try. So now we have covered what is MINOCA, who is more prone to get MINOCA, why it is important to diagnose MINOCA, how MINOCA should be investigated, and how MINOCA should be treated. Before going into INOCA, I'll present you another case. This is a 50-year-old female presented with class 2 angina, exercise ECG stage 3 positive, and repeatedly normal coronary angiogram. But patients coming repeatedly with the symptoms, and psychiatric referral also has been done. So, what is this condition? Is this INOCA? So, INOCA stands for ischemia with non-obstructive coronary arteries. Up to 70% undergoing coronary angiogram because of angina with demonstrable myocardial ischemia. Have no obstructive coronary arteries. So, our patient also has a demonstrable myocardial ischemia. Her exercise ECG is positive. And she hasn't had any obstructive coronary artery disease. So, this entity is called INOCA. So, the main two mechanisms accounts for INOCA are coronary vasospasms, which cause vasospastic angina. This clinical entity causes vasospastic angina, and coronary microvascular dysfunction. This clinical entity is called microvascular angina. So why it is important to diagnose INOCA? Because it's common. Because 70% of female and 30 to 50% of male undergoing coronary angios have demonstrable ischemia without obstructive coronary arteries. And it's not a benign condition. It can impair quality of life. It can lead to repeated hospitalization and unnecessary coronary angiography, increase healthcare costs, and increase incidence of cardiovascular events. And we can give tailored therapy. If we diagnose vasospastic angina, we can give calcium channel blockers. If we diagnose microvascular angina, beta blockers are first line. So we can give tailored therapy. So that's why it is important to diagnose INOCA. So who is more prone to get INOCA? Again, young women. Traditional risk factors, the role in INOCA is not well established. However, non-classical risk factors like estrogen fluctuation, inflammation, genetics, migraine, psychological aspects can play a role in INOCA. So how to investigate INOCA? So how to investigate those two main mechanisms, vasospasms and microvascular dysfunction. For the vasospasms, we can use intracoronary acetylcholine and assess for the large coronary artery vasospasm. If it is not there, we can identify microvascular vasospasm. And for the microvascular dysfunction, now there are objective ways to assess. So this is a graphical representation of assessing the INOCA and how to manage INOCA. So we have to initially we have to incorporate the lifestyle modification and risk factor management. And then if we diagnose vasospastic angina, the calcium channel blockers high dose is the first line. Then long-acting nitrates and nicorandil we can try. So if we diagnose microvascular angina, beta blockers, calcium channel blockers. Beta blockers is first line, but we can try calcium channel blockers and nicorandil as well. Statin and AC inhibitors we can consider. There's a large randomized control trial going on, which is name is Warrior, but still the evidence is less for statins and AC. And low dose tricyclic antidepressants, imipramine also we can try. This is again a graphical representation of management of INOCA. If we can diagnose the subtype, we can tailor the therapy. So we have in Sri Lankan context, do we have these hi-fi investigations? Yes, we have. We have cardiac MRI in some places. IVUS, FFR available. But vasospastic studies and OCT we are not doing. But we can try a therapeutic trial of calcium channel blockers if we highly suspect vasospastic angina. So take-home messages for MINOCA is 8 to 14% acute MI can cause by MINOCA. So no obstruction shouldn't mean no diagnosis. And there are heterogeneous causes which can cause MINOCA. If uncovered, cause-targeted therapy can be given. For take-home messages for INOCA, it's common, it's not benign, it's often misdiagnosed, and main mechanism is coronary vasospasms or microvascular dysfunction, and there are objective ways now to assess and stratified personalized treatment we can give if we can assess the major two types. So that will be MINOCA and INOCA, and these are my references, and thank you very much.
Thank you very much, Chathurika. We can have some questions. I have a couple of questions from the audience. The first one is Cornish syndrome considered as MINOCA?
Yes, sir. In some reports, it can consider as MINOCA because in the Cornish syndrome, because of the allergic reaction, intense vasospasms can occur. So in some reports, it can cause, it as considered as MINOCA, but not as a major cause. In this presentation, I tackle only the major causes.
I also had a question about your first case. You found that there was a dissection.
Yes, sir.
So wouldn't that count as obstructive?
So that's a very valid question, sir. Thank you for that question. There are subtypes of spontaneous coronary artery dissection. If the hematoma is very large, it can cause obstruction and we can pick it up in the angio as well. But the type 2, which is diffuse, usually cause haziness in the angio. It can cause the hematoma is there, but the hematoma is not large enough to cause the large occlusion. Usually that type we can't pick up in the angio. So the first type, it comes under obstructive coronary artery disease, but the second type, it comes under myocardial infarction with non-obstructive coronary artery disease.
So in this case, it was not visible on the angio.
No, sir.
Wouldn't it depend on the rotation on the plane?
Yes, sir. Actually, that's true. That's why we have to look closely for the misdiagnosis, overlooked diagnosis. We have to go back to the angios. We have to review them and see whether we have missed any haziness, any tiny obstruction before diagnosis of MINOCA. But in this case, we couldn't pick up any.
Would manage them as an ST elevation myocardial infarction, a vast majority of them. And a vast majority of them would actually not get an angio either. Still, it's a situation here. But when you went through the management, there are some drugs that we would normally use which are contraindicated in these people, which you wouldn't give. So my question is, how would you suspect that this is a MINOCA in a normal person that you would see in the wards?
Yes, madam. Thank you for that question. With the history, if the patient is not having any traditional risk factors, we can suspect. As an example, this patient with spontaneous coronary artery dissection hasn't had any coronary risk factors. She's a young female postpartum. That's why we didn't stop at angio. We went ahead with IVAS. So, with the history, we can suspect. Vasospastic angina, again history helps. They occur in rest and with ST elevation. So if we highly suspect vasospastic angina, we can avoid beta blockers. In emergency situations, we can try calcium channel blockers if the arrhythmias are continuing with the MI as well. So that's how we have to tackle, madam.
I have one more question from the audience. How does TCA help INOCA?
Sorry, sir.
How does TCA help INOCA?
Thank you, sir, for that question.
From the audience.
In INOCA, there is a psychological aspect which can cause the pathophysiology of INOCA. So it's not well established. The mechanism is not well known, but the studies have shown the lower dose imipramine can help in INOCA. So there's no overt psychiatric diagnosis, but low dose imipramine can help for the psychological aspects which can cause the pathophysiology of INOCA, which is not very known up to now, sir.
So is it possible that it's similar to something like IBS, where it has a modulatory effect on the nerves or the membranes, the neural membranes, and whether that's the effect? I'm just asking. Do you know anything?
It's not known yet. I'm not very sure, sir.
Because it could be the psychological effect, or it could also be some kind of neuromodulatory effect.
Neuromodulatory effect as well.
Yes.
I'm not very sure.
I didn't ask this question. Somebody in the audience. There's another question. Is nifedipine a better choice than diltiazem for coronary spasm?
Usually, diltiazem we use or verapamil. But I'm not very sure which is more beneficial. But usually what we use is verapamil or diltiazem, and we have to give very large doses for coronary.
So I think the question was about nifedipine. Perhaps it's the fact that nifedipine can cause a tachycardia or accelerate the heartbeat that is a reason why it's not given.
Yes, in the acute coronary event, usually nifedipine we do not use.
You can combine it with a beta blocker in normal circumstances, but you'll be hesitant
to... But the vasospasms, beta blockers are not very good.
I think that would be the answer, that since you can't combine it with a beta blocker, you wouldn't use a drug which accelerates the heart rate.
Heart rate.
Any other questions? Okay, that was a very interesting presentation. I learnt something quite new. I didn't know what MINOCA and INOCA were in the past, so we live and learn. In the absence of further questions, I would like to thank you, Chathurika, for your excellent presentation, and nothing further. Thank you very much. And there's a small certificate.